Welcome to the next episode of Mic'd Up with ChiroUp. We got Tim and Brandon for this episode, and we're going to talk about the most underused tool in chiropractic. Re-exams done right and for the right reasons. And I think that that's one of the biggest issues that I had, at least beginning in practice, is really why am I doing a re-exam? Am I doing it for clinical clarity? Am I doing it for better reimbursement? Or really am I just doing it because I'm forced to do it by some insurance entity? But really what I'm trying to do is I'm trying to avoid patient noncompliance. And I think that's one of the things that we can use in a re-exam to show them progress and also show all the other entities that are looking at my note what's going on with that patient. So welcome to the #1 podcast in chiropractic. Technically, that's not right. However, we are the top 5 in Apple and Spotify, and with your help, we have been climbing. If you're really looking to find a podcast that is going to support our profession positively, it's really going to keep things evidence-informed, and I think this is something that Tim and I enjoy doing. Please give us a like, drop a comment, so we can keep on doing this and really bring the forefront of the perception of chiropractic to the masses. So before we dive into all of that, dive into the topic that really every chiropractor wrestles with. Dr. B, do you enjoy doing re-exams?
I love re-exams. Actually, unfortunately, I forget them. So remembering to do them is probably the hardest part of the re-exam. And we'll talk about tools to do that. But more importantly, we'll discuss why re-exams are one of the more underutilized tools to improve our patient outcomes, to communicate with patients, and absolutely reimbursement.
So here's a better question. Have you ever looked at an EOB?
What would that be?
It's one of the humbling pieces of being a chiropractor at the very beginning is I was very fortunate. In fact, Dr. Bertelsmann gave me a job, and my job was to treat patients. And
we all make mistakes.
I was very sheltered. And I'm going to be completely honest, I would say the first 10 years, I had never seen an EOB. I had no idea what I was getting paid for. And then realistically, once you start to get into practice, then you start to realize the business aspect of doing a re-exam. However, that's not why we're doing this podcast. The reason we're doing this podcast was a conversation I had with a patient. This was about a week ago, and she had just undergone SI joint fusion. Now, as you can imagine, she's in my office, so she's probably in my office for a reason, and it was because she still had some posterior buttock pain. However, the reason we're doing this podcast is because the conversation we had is because she went back into the surgeon after her fusion, and the surgeon told her, great news, the fusion was perfect. And she looked back at him and said, well, then why do I still hurt? And this is the classic disconnect. Now, I don't perform surgery. However, this is the same disconnect that I can have with my patients because that provider was measuring success by structural integrity. He got in there and did exactly what he was supposed to do, and it worked. However, the patient was measuring success by pain relief. And when expectations don't match, trust erodes, and that really is going to happen no matter what profession you're in. And this re-exam, and in that case, it was a post-surgical re-exam, but this conversation, this happens every day in chiropractic. We face these same challenges, that our adjustments might be flawless, our treatment plan matched the diagnosis, but the patient still doesn't feel better. And maybe it's not the end of their care plan, but maybe it's in the middle of their care plan, and they're starting to feel like, and possibly you're starting to feel like you missed the mark. So something's not quite right. And you'll see the look in a patient's eye. If you don't get a pop during manipulation, automatically the treatment didn't work. Your diagnosis was off. I mean, you might as well go back and work at a hardware store. They're looking at you like you're crazy, like nothing's working if we're not getting pops and cracks. And you and I know that's not the same thing. However, we have to manage these misconceptions on a visit-by-visit basis.
Yeah, you bring up a great point that there was research that you detailed in a blog, probably the second best blog we've had on the POP.
Because you wrote the other one.
Could have. And the expectations are that if a patient believes that that sound, that audible release, is responsible for them feeling good, and the reason they believe that is it's a Pavlovian response, that they've heard it many times, they felt better afterwards, so their brain says, hey, when you hear this pop, you're going to feel better. Well, we know through multiple studies that the pop really has very little to do with it. It's not the cavitation, that audible release. It's the movement that we're imparting into that segment and everything else that we're doing around it. But if a patient believes they're not going to get better unless they hear that, they won't many times. Their expectations aren't aligned with what they're experiencing. And that's what re-exams do. That's our opportunity. That's our roadmap. That if we're planning a trip that we want to go to Florida, every now and then we have to look up and say, what's the mile marker? What highway are we on? And that's what re-exams do as well. They recalibrate that patient's care plan and allow us to realign expectations. Where do we sit? How far along toward Florida are we? We're 50 miles of the way there. We're 300 miles of the way there. We can let our patients know what they're seeing what you're seeing in the exam and how that's relating to their symptoms, and validate that we're paying attention. Obviously, we're going to do re-exams anytime a patient has a new presentation or a new injury. And then we're going to establish a care plan that we see them for 6 or 9 visits, and we'll reassess. So we're going to do a re-exam at that point. If a patient's not responding along the way, we're going to do a re-exam. But it's not just those clinical guideposts and communication that are important. It's also the patient compliance, that compliance with them understanding where they stand and why they should continue care. And our compliance with insurance companies, that insurance company needs to see that things are changing or things are not changing, and we're changing our care plan in response to that. It protects us from a lot of things. It protects us from post-payment audits. It protects us from malpractice policies, and it shows that we're performing to the standard of care. So not just the clinical reasons, but also the business reasons of doing it.
And I'll bring up not a business reason, but patients don't drop out of care because they're healed. Even if they are completely out of pain, if there's still more you can do for them, like working on strengthening muscle or working on balance, those are all things that you can do after that initial care plan is done, and the re-exam kind of lead you into that, finding other parts of the body that may need to be treated or functional goals that are looking to be met. So if patients drop out of care because they feel unheard or they're not really sure why they should continue. So I think that's one piece. The other part is if they're not getting better. That's when we start to think about, okay, if they're not improving, am I missing something? Am I missing a second diagnosis? Am I treating the right diagnosis, the right area, the right structure? So that's really one of the biggest things that I'll see in chiropractic practice, because there was a study showing that 50 to 70% of patients don't have pain at just one site. They have multiple sources of pain. So even when you're treating one thing, can we start to see pain present in a different region or start to radiate somewhere else? Because as you're solving one problem, is there another one taking center stage? Are you peeling back layers of an onion? And those are things that we can assess and also start to develop plans around during these re-exams. So one of the things we want to think about is, are these people in chronic pain states? Are we seeing neurologic progression? Are we seeing loss of function? And then obviously, we're all doing red flags during our initial consult, but are we starting to see the presentation of new red flags during the treatment trial of care? And then, not that you would have this, and definitely not Dr. Berlesman, but are we seeing non-compliance? I had a patient look me in the eye yesterday and say, no, I don't want to do your exercises. You know what? That's okay.
I didn't.
What do? I just elongated their treatment plan. Like this is going to take a little bit longer if you're depending on me for this part of your care plan. And then finally, I think that this is one of the missed pieces that I know helps me out a lot. I know in our initial intake forms now, we ask yellow flags. And while I used to think that was a hindrance, now when I look at a patient intake form, I look at their subjective, and I'm sitting there in front of the patient asking their questions, and I see on there that patient answered, I don't feel like this pain is ever going to get better. I don't feel like I'm able to, manage my symptoms. Well, that's a whole nother level of diagnosis, a whole nother level of comorbidities that I need to address during my report of findings, and then definitely every single office visit focusing on the psychological aspect of, are they getting better? And don't forget, this is another way to objectify what that patient's telling you, to put in your note to justify more care or the elongation of care if they're not meeting their treatment goals.
Yeah, first of all, that exercise you asked me to do, I had never seen that in any of the rehab books before.
It's called a push-up.
You need to start where the patient is. You can't take them right to the end of the highest level right off the bat. So our re-exams also allow us to think, are there other options that are needed, like imaging? Initially, when I graduated from school, the criteria, this is a soft lob.
He looked at me. I was going to let you go on that one.
Good. We'll discuss that later. The criteria for do we take a film was, does the patient have a spine? And now kind of the criteria for do we take a film initially is their spine hanging outside of their body? That the guidelines have really moved in a definite direction of not imaging things, and that's okay initially if that's your style of practice as well, and we should all be following guidelines. But if a patient is not improving, then it may be time to take a little bit closer look. So anytime that I've completed a care plan of 6 or 8 or 9 visits and that patient hasn't met my goal, that means that either my diagnosis was wrong or my treatment was wrong, or potentially both of them were wrong. And if my diagnosis is suspect, then some tests may help me to nail that down. So that's a time that usually I'll pull the trigger on imaging a lot more frequently, is at that first re-exam. If those patients' symptoms haven't improved at that point in time, especially if they have any worsening symptoms, especially if they have worsening neurologic deficits, and especially if those deficits are upper motor neuron lesions, now we're really concerned, because that's a red flag. And then all the other red flags as well. Do they have any constitutional symptoms like unexplained weight loss or fever or fatigue? Do they have any significant things in their history that maybe we blew off initially, that they had a simple cancer 30 years ago? Now we definitely want to take a closer look at that and say, yeah, we're going to do imaging. And do they have anything that might indicate something more serious as far as a cauda equina type symptoms? Those are not overreacting. It's always better to pull the trigger a little later than a little late. It's always better to tell the patient that, yes, we did this test and it was negative, than have to explain that a few weeks later saying we should have done that test because it's positive. That's the standard of care. That's how we protect ourselves, protect our patient, and make sure that we're on the right track, on the roadmap.
Don't worry. I looked it up. X-rays were actually invented while you were in school. It was 1895 by Wilhelm Conrad Röntgen. Rontgen. He won the first Nobel Prize in physics in 1901. I did not know that. I remember him x-raying his wife's hand. It was, I think, the first image. I do remember that from school, but that's about my expertise in radiology. Let's go through the business case rules for re-exams. And there's a couple rules or templates that we can follow. However, once again, we need to make sure that we're keeping the things that we need in our note associated with re-exams compliant. Most of us are going to use more of the MDM elements. What are the things we're putting in our notes to allow us to bill out for that? And we really have to have 2 out of 3 elements. Now, the first one is number and complexity of problems addressed. So if you're addressing just 1 or more chronic conditions with any kind of exacerbation, progression, or side effects, something you can have as a qualification, or 2 or more stable chronic conditions, that would fulfill that requirement. Number 2, amount complexity of data reviewed. Now, this is one that I honestly pride myself on. I'm sure you do also. And that's using orthopedic testing. It's using other kinds of testing like x-rays, like MRIs. And then one thing that's often overlooked, even if you're not doing x-rays in your office, is one, making sure you put that in their note, download it, put it in a PDF, put it in the digital note. And then letting your note know that you received that and putting the findings in there. Because if it isn't in your note, it never happened. So if you review any kind of external notes, and really if it's even from another provider or the emergency room, make sure you get in that digital chart and make sure you make some kind of notation that you looked at it, you read it. I even initial the paper copy before it gets sent into the EHR. And then finally, this is one of those risks of complications or morbidity. So if we have a diagnosis and it's at risk of becoming a chronic condition, that's something we want to make a note of. And then if they're having any kind of progression of neurologic symptoms, one, of course, make that notation at the very beginning. But then when that re-exam hits, make sure you're re-documenting. I look at my re-exam status or my page or the questions that I ask. It's really about, can I tell that reviewer a story of what's going on? Even if they've never met me, they've never met the patient, can they kind of see what's happening with this patient? So if you make a documentation of any kind of neurologic deficit, make sure in your re-exam you go back to that exact same deficit and explain how it's changed. And of course, the same thing with any kind of muscles or orthopedic test. And then finally, I think that one of the often missed pieces is how do you take a subjective finding and turn it into an objective finding, is listening and measuring ADLs, or listening to them when they want to walk around Target for more than 5 minutes. Then you go through 2 weeks of care, but their pain's still at 10 out of 10, but they're now able to walk around Target for 15 minutes. Well, that's an improvement. You're showing that maybe pain is still constant, but we're seeing improvement in functional limitations or work-related abilities or whatever it may be when it comes to that person and what they're trying to accomplish and coming to see you.
Yeah, making sure your note reflects that as well, that in your assessment or plan section, if you ordered a test, explain why you ordered the test. It's just not okay to say I've ordered an X-ray or an MRI. You might want to say that the patient continues to have some lower extremity numbness or weakness, so I ordered an MRI to assess for a potential disc herniation. Or maybe that patient's progress is not as quick as you would expect. And if the reviewer is looking at that and there's nothing documented, they're going to see that the objective findings aren't changing, the subjective findings aren't changing, and they're probably going to cut care. Whereas if you can document something like due to the patient's missed visits or poor home health compliance, or their schedule at work, their recovery time is extended. So we discussed some care plan adjustments, and we're going to extend the care plan for a couple of weeks. So making those notes in your record can go a long way to validate the care. And so what does the research tell us about not doing re-exams? Well, we know that when care fails, the biggest issue isn't poor outcomes, it's poor communication. The patient didn't know where they were on the map. Patients don't expect miracles, but they do expect updates. They expect honesty and a plan. That you've sat in an airplane before at the airport and you're waiting to hear when's the plane going to take off, or why are we still sitting on the tarmac. It's okay as long as you're updated. You might not be happy about it, but you understand. You want to jump off the plane when you don't know when that plane is going to leave. So re-exams create that bridge to let the patient know here's where you are on the journey and here's where we're going and what you can expect. A couple of stats from the evidence. Spine Journal told us that about 30% of low back pain patients have persistent symptoms after 12 weeks. That means that if somebody's not significantly better in the first 3 or 4 weeks, they're not necessarily failing care, but they need to know that. They also need to recognize, and we need to recognize, that if there are yellow flags in that patient's history, that predicts that it's probably going to be chronic. So we need to address those biopsychosocial aspects, letting the patient know if they have fear of movement, that movement is okay. And also, we know from British Medical Journal a couple of years ago that if we have delayed referrals when that patient does need mental health help, or when they do need a physiatrist, or they do need a neurologist, or someone else on board, that when we delay that, the outcomes are going to pay in a big way.
Yeah, I think that's one of the hardest things to do as a provider, is to not be great at everything. Not that I'm anywhere near that, but I'm not a dietitian. I'm not a psychologist. In fact, I could probably put a couch in my treatment room. You hear about a lot of random things. However, is to recognize the things you're not great at and getting them in the right hands. So making sure you have those referrals for a massage therapist, a dietitian, a psychologist, a pain management doctor. Having all those people at your disposal will help getting the person we're still on the same plan, but we just may need a little bit of help. Your van's breaking down. We need a couple new tires. So practical takeaways before we dive into some more fun stuff is that the remembering piece. Making sure at the very beginning to set a reminder of when you're going to do a re-exam. Now, I do this in the schedule and goal section in the EMR that I put on there. Listen, I'm going to see you 3 times a week for 2 weeks. And then now I see a countdown. And when they hit the countdown of 0 as far as the visits, I know next visit is a re-exam. I know that I'm going to deliver some exercise to the patient automatically. I'm going to deliver some questions to the patient automatically. And those questions are going to be based off the questions that were asked at the very beginning of care to show that functional improvement and progress. I also know that you're going to have some kind of validated tools Now, the validated tools are your oswestry, your neck disability index, your lower extremity functional score, your DASH score. So we need to objectify subjective findings at the very beginning, and we do that with automated surveys. And then don't forget to do that again and make sure you use the same survey. Don't ask the oswestry, then the DASH index. That's not going to show the progress that we're looking for. So use validated tools to show the progress. And then communicate this. And remember that better and worse don't mean a whole lot. We need to have that in our note, but we need to say what's better. Well, pain's better and walking around Target's better, and we're able to sleep better. So whenever you can start to ask more questions of the patient, you have more ways to show your note and to show whoever's looking at your note kind of where they are and where they are currently are and where they're about to go. And then finally, comorbid diagnosis. This makes a big deal when you look at the complexity of codes that you can use. So not that I'm looking to bill more and more for my patients. However, if I need to spend more time with a patient and I need to look at more documents with the patient, I need to order more tests, there are codes that are justify that increase in time. So making sure you use a review of systems when you first take on a case, look at that review of systems, and then comment on those positive findings as that person goes through the trial of care in your office.
Yeah, so what I've heard today is that re-exams really tell us where we are on the map, that you'd never go on a long journey without looking up and seeing where am I. That tells us, are we doing the job right? Are we on the right track, or do we need to do something differently? They also allow us the ability to align that care with the patient's expectations. And relaying, Mary, when you came in, you could only rotate your head 30 degrees. Now you're at 45. I know that you still have discomfort when you wake up in the morning, but your range of motion is improved by 50%. I'm no longer feeling joint restriction at C6, and that orthopedic test that used to be positive, it's not positive anymore. So those objective signs can go a long way for the patient, and they also protect us legally. They protect us from a reimbursement standpoint, and when done properly, re-exams obviously pay for themselves. That we as chiropractors have basically one thing to sell, and that's our time, and we have to use it wisely. And re-exams are something that we can get reimbursed for in most cases, and is a wise use of our resources.
Yeah, so I'll wrap up with the re-exam, and then I'll focus a little bit on a new piece of functionality, voice to chart, and how that can be incorporated to solve some of the problems that we just discussed. But kind of my final thoughts on the re-exam piece is that, if you want to stay out of trouble with payers, boards, malpractice lawyers, that's one thing. And we have to have re-exams. But really, I look at these things, these re-exams, to keep patients on board, to make sure that they are part of their care. This isn't just something we have to do. This is something we should want to do. The patient and the provider should want to do to make sure we're on the right road. And eventually, we're going to make it to Florida.
So you had mentioned something, and
was it a push-up program?
It was, yeah. I've already forgotten that. My therapist is walking me through it. But the biggest problem that we face, the biggest challenge that we face in chiropractic, as we surveyed our subscribers multiple times, was surprisingly taking a SOAP note. That's the one thing that everybody dislikes the most. In fact, that was the biggest complaint out of the hundreds of chiropractors, even above reimbursement.
Why was this? I mean, I love doing notes at the end of the day.
I know. I did too. It was really meaningful to sit in the car and use your dictaphone and then get it transcribed. So there were 3 points in this journey over the past few years that I've been super excited. The first one is when we dumped out the OPPQRST survey. So rather than having to sit down with the patient, now when they come in, they give me, I see on their chart that they've filled all this information out. I can ask a couple of clarifying questions, and I've reduced my consult time from 15 minutes down to 2 or 3 minutes. That has been huge. And so that was super exciting. That took a long time to build. And then the second one is when we released the EHR. So anybody can use the OPPQRST. It's just part of ChiroUp. The EHR users can now use the SOAP. And the great thing about the SOAP is that we leveraged all of the ChiroUp resources, so that the way a provider typically takes a note is they review that subjective, which is automated. They then assess the patient and they treat the patient, and then they go take their note. Well, by the time you take your note, you know what the diagnosis was. And if you know what the diagnosis was, you probably know what tests you did and what treatments you did based upon your protocols. So that was the second most exciting, because it took my note taking down to maybe 30 seconds for a new visit and maybe 5 to 10 seconds for a follow-up visit. And so I was super excited about that. Now the third thing that our coders have just released, it's just one after the next, and this one is the voice recognition or voice to chart. And so the patient fills out that automated OPPQRST survey, but oftentimes there are some details in there that you just can't put into even the most intuitive automated survey. So our survey is not just a bunch of questions that are stock. It's intuitive, and they change based upon the prior responses. But there are still things like the patient says, when I sat at my son's baseball game the other night, I started to get some numbness in my third digit. Well, that's kind of challenging for any survey to pick up, but they tell you that in practice. So voice to chart works with the amount of labor of touching a button before the patient walks in the room. It listens to what the patient says, and I touch a button at the end of the visit, and then it summarizes exactly what the patient told me. Dumps it in the chart. I can still edit that or do anything that I need as far as modifying that. But it saves all that time of the extra time of adding those details. And I think out of all the things, I think I've probably been most excited about that. It's just a massive time saver. And it's almost, it's kind of like a slot machine that you pull it and you get excited what comes up. Was it 3 strawberries or was it 3 gold bars? And it's always amazing to see what comes up from the synopsis, that the patient can be succinct or they can ramble on forever. And you get this incredibly succinct yet comprehensive report of what they said. It's like magic every time. It's like getting to play a game each time. So that's the third thing that should be released by the point that this podcast is out. It should be released within the next week or so. We've been using it for months. Our beta clinics have been using it, and we can't wait to hear your feedback on it.
Yeah, one of the things about this is that, one, it's super quick. It's compliant. That's one of the things that I'll hear from other chiropractors. Oh, I do it X, Y, and Z. I'm like, well, you can't do that.
Yeah, dump it into ChatGPT. You?
Well, with copy and paste, we're talking about hitting 2 buttons, and that's it. So that's pretty fast. Well, it can't be any faster. And then I think that the other piece is that it stores the consent. So the first time you do that with a patient, it'll say, hey, you need to, legally, you need to let the patient know what's going on. And after you do that with the patient, you click that. Now you have a consent in your actual chart, and then it will no longer ask you that, which is pretty nice. The second part of that is it really works well for the subjective piece. So for the subjective conversation with the patient, it takes seconds. I think that we're still in the alpha phase of that, but really the beta phase of how can we use AI in all the other pieces, SOAP note and all the other billing. So this is just the tip of the iceberg. We've got some coders that are just excited to get working on, how many codes did you bill last time? How can we look at your reporting? How can we look at your billing? How can we look at your scheduling and determine where you're going to have holes? And how can we really use and leverage AI to make you a busier chiropractic practice? So at the end of this, really at the end of the day, we hope this kind of information helps. If you have any more questions, concerns, you can always email me, Brandon@ChiroUp.com. If you have any criticisms, it's Tim, Tim, at ChiroUp.com. He always appreciates those. But if you really enjoy this episode, please share with a friend, share with a colleague. If you find anybody that's inspired by this kind of information, share this kind of information with them. We'd love to have them listen to the podcast, or at least be able to get that information out there to our profession. This podcast is all about pushing our profession forward, and you can help us spread that message by hitting the follow button. And until next month, have fun in practice.